Hello, everybody. Good to see everybody. Or I can't see everybody. You can see us, but we're going to welcome you here with a little musical beginning and a song that should give us all pride about where we are from. Here's how it goes, and feel free to sing along. Well, I got a mule and her name is Sal, 15 miles on the Erie Canal. She's a good old worker and a good old pal, 15 miles on the Erie Canal. Well, we hauled some barges in our day, filled with lumber, coal, and hay, and we know every inch of the way from Albany to Buffalo. Well, Low Bridge, everybody down. Low Bridge, 'cause we're coming to a town. Always know your neighbor and you always know your pal if you ever navigated on the Erie Canal. Well, giddy up there, gal, past that lock. We'll make it home before 6 o'clock. So it's one more trip, and then we'll go right back home to Buffalo. Well, Low Bridge, everybody down. Low Bridge, 'cause we're coming to a town. You always know your neighbor and you always know your pal if you ever navigated on the Erie Canal. Yes, you never know your neighbor and you never know your pal if you ever navigated on the Erie Canal.
Thank you so much, Dr. K. That was beautiful. You're so talented. Good afternoon, everyone. On behalf of our partners in the health sciences, welcome to the UB Health Sciences Distinctive Dialogue Program on transforming the future of mental health at UB. My name is Amanda Rebeck, and I am the Associate Director of Advancement at the UB School of Nursing. As we celebrate UB's 175th anniversary, we are proud of programs such as this, where we are able to bring our experts in the health sciences schools together and share how we are developing new ways to address and train our mental health experts and assist with the impact it has on the overall health and well-being of people living in Western New York and beyond. As an academic health center, we feel we have a unique opportunity to highlight programs like mental health, wellness, and others that show how UB is facing the issues directly and finding solutions throughout interprofessional education, training, community partnerships, and research. Without the valuable support of our alumni, donors, faculty, and students, we would not be able to accomplish everything we do, and we thank you for your support. It is now my pleasure to introduce today's moderator, Dean Marsha Lewis from UB School of Nursing. I'd also like to congratulate her and the School of Nursing as we are just finishing up our celebration of Nurses Month. Thank you to our nurses and all the healthcare workers for all you do to care for others. Marsha?
Thank you so much, Amanda. And thank you, David, for the music. I was remembering a couple of years ago, we took a boat ride on the canal and they sang that song while we were going down it. It was wonderful. Well, good afternoon and welcome. We have a wonderful group of people here, and I hope that you are going to be able to enjoy and really learn some things from our wonderful panelists. This is the UB Health Sciences Distinctive Dialogue Series, and it's my pleasure to be moderator today, joining our experts in mental health so that we can share more about how we're transforming mental health care, education, and training at UB. Our overall goal for the Distinctive Dialogue program is to connect our donors, alumni, faculty, and students, and to provide important topics such as this one. With May being Mental Health Awareness Month, and by the way, as Amanda said, Nurses Month, and COVID amplifying the importance of mental health as fundamental to overall health and well-being, we have many reasons to partner with our health sciences schools to present this topic today. My career has been spent as a psychiatric nurse in practice, teaching in undergraduate and graduate programs in nursing, and supervising students in psychiatric settings, particularly primarily in child and adolescent units. Over the past 25 years, my research has focused on primary prevention for family caregivers of persons with dementia. The psychoeducational program that my interdisciplinary team developed is aimed at helping caregivers to develop knowledge, skills, and attitude they need to care for their loved ones while maintaining their own physical and mental health. Along with everyone else, the faculty in the School of Nursing have seen the effects of COVID on themselves, their families, and their students. Our Nursing Emergency Fund for students has been inundated with requests for help. Our faculty see and try to address the stresses related to being successful in a rigorous nursing program. We've been fortunate that our students have been successful in graduating and in passing their national examinations this past year. I would love to share so much more with you, but we really need to hear from our four panelists. So let me introduce you to them. First panelist, Dr. David Kay, is Professor of Psychiatry and Vice Chair of Academic Affairs in the Department of Psychiatry at Jacobs School of Medicine and Biomedical Sciences. As a child and adolescent psychiatrist, he provides care for children and adolescents as developing individuals and as members of family, community, and culture. And I suspect that some of his music comes to play in his treatment also. He's also closely involved in the educational programs of the department and in recruiting and training residents and medical students. Welcome, David. The next panelist is Dr. Dory Marshall. She's an alumna of the Jacobs School, Assistant Professor of Psychiatry, and Dean of Admissions at the Jacobs School of Medicine and Biomedical Sciences. She provides holistic care for adolescents and young adults as they transition into adulthood, and works to provide the best care possible by eliminating assumptions and getting to know the patients in meaningful ways. In addition, Dr. Marshall leads the school's admission team, fostering an understanding of each applicant's passion and motivation for medicine, and has an appreciation of the diversity each applicant brings. Every year, she oversees admission of 180 medical students at the Jacobs School of Medicine. Welcome, Dory. My colleague in the School of Nursing, Dr. Yuping Chang, is the Patricia H. and Richard E. Garman Endowed Professor and Associate Dean for Research and Scholarship. She's a professor and also chair of the Family, Community, and Health Systems Division. Dr. Chang's research focuses on geropsychiatric nursing, and her areas of interest include substance abuse and depression in older adults, as well as dementia care. She has numerous interdisciplinary training and research grants to integrate behavioral health into rural and underserved primary care clinics, expand the opioid workforce for high need and high demand areas, and to compare interventions to mitigate the impact of COVID-19 on mental health among adults from underserved and racial minority communities, just to name a few. Thank you for joining us, Yuping. Finally, Dr. Catherine Dulmus. I knew I was going to get it wrong, Catherine. I'm so sorry. Catherine Dulmus is alumna of the School of Social Work and professor and associate dean for research and director of the Buffalo Center for Social Research at the School of Social Work. Her research focuses on mental health, evidence-based practice, and community university research partnerships. Her current work is an exciting collaborative project building a data warehouse to improve client out to support data-informed practice across 14 rural counties in New York to improve client outcomes. Prior to obtaining her PhD in 1999 at UB, Dr. Delmas's research social work practice background encompassed almost a decade of experience in the fields of mental health and school social work. Welcome, Catherine. We begin our program with 2 rounds of questions for our speakers before we open it to audience questions. So please, if you have thoughts and questions, write them in the chat and we will get to them as many as we can. We begin with Dr. K. COVID-19 has had a great impact on children and young people. How are we now going about clinical care at UB? What are you seeing in your practice, and how do we build the awareness of everyone who works with children to identify signs and symptoms of mental health issues?
You're muted, Dr. K.
Thank you. A lot in there, and let me try to speak to those issues. I think we're going to hear more about some of the research a little bit later on the impact of COVID on kids and adults, but obviously it's been huge, and that has not just been physical, but it's been in mental health as well. We here at UB, we have seen we have a number of services in children's mental health and child psychiatry that range from the Comprehensive Psychiatric Emergency Program at ECMC, which sees kids as well as adults, to our adolescent inpatient unit at ECMC, to our consultation services at the Children's Hospital, to a robust outpatient clinic at Children's Hospital, as well as a number of consultation services that we provide to primary care, which is something that's close to my heart, and a program that I've been very involved with called Project Teach, which is an OMH-funded program that covers the state of New York to promote the education and provide consultation support for pediatric primary care providers. So our program, which is a collaboration of 5 universities across New York, and we're the lead institution on this. We provide the education and the consultation support for primary care. And so this has been a wonderful project over the last 10 years. And in foreshadowing about the future, I think that's where the future is going to go for mental health and trying to meet the needs of kids. That's one major avenue, is looking to primary care to be more comfortable, confident, and competent. I didn't hear that, but in any event, so at UB, we're involved with many aspects of the clinical care of kids and adolescents. And we saw in the last year a huge increase in the numbers of kids coming to the emergency room at Children's, to CPEP, and this was mirrored by our outpatient statistics, which were the highest they've ever been. So we saw a huge increase in the demand for services. We're running as fast as we can to train folks to meet this need, but it's not easy. So what can we do to build awareness? There are several really wonderful programs in the community. One sponsored by the Mental Health Advocates of New York called Just Tell One. a wonderful public information outreach and education program. The Suicide Prevention Coalition of Erie County, led by Celia Spicone, has just been doing wonderful things, has many programs for the public in identifying, talking to kids about suicide, and promoting linkage with resources for those kids. And the Parent Network also is another wonderful resource in the community, doing a tremendous amount of education in the community. Also at UB, we do a lot of education in the community, particularly with schools in Buffalo Public Schools and Niagara Falls Public Schools. So I think there's a lot going on there, and those are some of the highlights.
Thank you, Dr. K. Your comments about primary care, I think, are incredibly important. I know that in the School of Nursing, we have had many more nurse practitioners come to our psychiatric mental health certificate program. They may be a family nurse practitioner in primary care and realize they need the knowledge and skill to be able to work and work with kids and adolescents and adults who need more of a focus on mental health. So I'm glad to hear that we're doing this in a number of schools at UB. Our next question is for Dr. Marshall. Similar to Dr. K, can you talk about COVID's impact on mental health of adolescents and young adults, and what disorders, trends, and symptoms you may see more of today than you have before? And how has your approach to clinical care transitioned over the years to meet the needs of this age group?
Thank you, Marsha. So I think that before we sort of think about COVID and its impact, we have to remember that over the last decade, from 2007 at least through 2018, there's been a huge rise in suicide rates among our young people ages 10 to 24, and it's increased by 60% over that time frame. So, you know, that has been something that we've been dealing with and contending with clinically, UBMD, psychiatry, you know, through our programs at ECMC and at Children's Hospital, particularly for years now. Anecdotally, since COVID hit, what I've seen at ECMC is a surge, as Dr. K said, in the intensity of illnesses and the number of children presenting for evaluation, both at Children's Hospital and at Erie County Medical Center Comprehensive Psychiatric Emergency Program, or CPEP. There's just been a big increase in the intensity of anxiety, depression, bipolar illness, and psychotic illnesses. And we see that both on the adolescent unit at ECMC and also on the first episode psychosis unit, which is for people approximately ages 18 to 30. It's interesting, the absolute number of patients hospitalized from March of 2020 to March of 2021 is slightly lower than the absolute number of patients hospitalized the same year, the same time frame the year prior. But the length of stay has been longer for our patients, and they've been sicker. And we've been at full capacity almost the entirety since COVID started till today. You know, if you look at, there's an American Academy of Pediatrics article in December of 2020, it says, it shows that a study in Texas found increased rates of suicidal, you know, ideation and suicide attempts were increased during the period of COVID. I think in Erie County, it's not clear that we've had that increase, but we have certainly had an increase in the intensity of illness. And I think that when the dust sort of settles after COVID, I think what we're going to see is that for children and adolescents who are from families that are the most stressed by COVID, and this isn't a surprise, those are the children who are going to have the greatest impact on their mental health. So children whose parents are essential workers and have been out of the home and not able to supervise them when they're doing homeschooling, children whose families have lost income or lost their jobs. There's certainly been increases in domestic violence, and that impacts our children. And so we have address those needs on a daily basis, taking care of these children at ECMC, and then in their aftercare, transition them to outpatient care that's mostly telehealth, but also ensuring that there are services that can go into their homes and follow them once they leave the hospital. And one of the programs that I'm just going to mention briefly is a program that connects the first episode psychosis patients at ECMC with outpatient follow-up in a first episode psychosis outpatient clinic to really try to help those young people who are first experiencing a psychotic illness, bring in their families and provide intense education about the course of their illness, if they remain in treatment or if they don't. And so that is one of the programs that has been very helpful for us during this last year.
So much. And as I was thinking about your population, that certainly is the age group of all of our students, primarily our students at UB. And so it's something we always need to pay close attention to. Next, I have a question for Dr. Chang. How is nursing working together with other schools and also with the community in addressing mental health issues? In your opinion, where is there room for opportunity? I'm sorry. No, never mind. I asked you the question. I'm out of order. How sorry I am. My page just got out of order, and I'll ask you another question. How's that? How about this one? How has technology been beneficial during the COVID pandemic to helping people? What have been some of the obstacles and challenges, and what do you hope will continue? What needs to be changed?
Thank you, Dean Lewis, for the question. The outbreak of the COVID-19 pandemic has resulted in a major transformation in the way the mental health interventions are delivered in the US and the world. And obviously, there has been a significant increase in telehealth visits during the COVID pandemic. Telehealth technology has afforded us a wonderful opportunity to continue to serve people's needs in a variety of ways. And there are different types of telehealth modalities, which include telephone delivered therapy, video conferencing, mental health apps, and internet delivered interventions, just to name a few. The advantage of telehealth has been numerous. Mental health providers have been reporting that on average, they are seeing fewer no-shows to appointments. And as a result, they have been seeing better outcomes with patients on treatment plans. This is actually also reducing costs for patients too, less travel and the costs associated with that. But also less interruptions or breaks in their treatment, which reduces costs over the long run as well. Clinicians also reported better clinical flows, meaning that the time and effort they are putting into the delivering care is improving due to the shift to virtual. And of course, there are some challenges in telehealth. Some clinicians have a strong preference for in-person treatment, and some just don't have a lot of experience with technology delivered treatments. And of course, this can go for users as well, who just are not comfortable with using technology. And some small practices have struggled with equipment, or they don't have the trained staff to troubleshoot technology-related issues. For the users, there can be questions about privacy, depending on where a person lives and with whom they live, and how are these sections being conducted privately on the user's end. And also there are social determinants of health, which can adversely affect some people's ability to use virtual care, especially if one of their social determinants is poverty or lack of internet connection. And we are seeing that in disadvantaged and minority urban areas, as well as in some rural areas that lack infrastructure for high-speed internet or even reliable cell phone services. So the digital divide in terms of digital literacy and affordable technology and internet are challenges to the telehealth. So lastly, there can be an issue of trust. Some people just don't trust that they will get the same quality of care if they are not in person with a provider. And of course, telehealth is likely here to stay. Many clinicians feel that the benefits of telehealth are hard to ignore and plan to continue offering telehealth services post-pandemic. Thank you.
That we've been working with telehealth for a number of years in the School of Nursing. We've had a couple of HRSA grants that have, and UPeng's been ahead of some of those. But it's a really important piece, I think, that the clinician has to be comfortable with the methodology. And in fact, we're going to be developing more and more a telehealth program at the School of Nursing with some funding to open up a room where it can be HIPAA compliant and all the kinds of things we need to be able to help our students do the best job they can while using that modality. I remember one of our faculty, who's a child nurse practitioner, said, I've had fewer missed appointments from my patients because that they're not having to travel. So if they have the technology, then at least the travel issues are. But there's lots that we need to do. Thanks so much, Dr.
You're on mute, Marsha.
I thought I unmuted and I didn't. We understand the UB School of Social Work has an important project that is also harnessing technology to transform mental health treatment services in rural communities in New York. It would be great if you could share that with us.
Thank you. And I appreciate the opportunity to share the work that we're doing in the School of Social Work. Myself, along with Dr. Greg Weiling, who is chair of the Biostats department within the School of Public Health and Health Professions, he and I together are co-PIs on a 2-year project that is funded through Integrity Partners for Behavioral Health, which is a collaborative of 24 mental health and substance use service providers across 14 rural counties in this part of New York State. The initial focus of our project is in developing a data warehouse, and which contains large amounts of historical data from many different sources. And then that's used for reporting, running queries, data analysis to discover trends, improve practices, and so forth. It's a wonderful tool to be able to really answer a variety of different questions. So why a data warehouse? I thought I just would talk about it briefly for a moment. We certainly live in a world where data is continuously captured, but really to answer meaningful questions, data must be gathered and organized in a certain type of way and be representative of the larger population that we want to help. Often we do this through, prospectively. We establish a research question and then we gather the appropriate data according to a pre-specified plan around a particular question. And an example of that would be the vaccine trials that we're all familiar with at this time. And although the result is certainly high quality research, we are limited generally only to the data we prospectively gathered. What's nice about a data warehouse is that we can answer a huge volume of important questions, pre-specified or not. We can answer questions pertaining to the general population or look at important subgroups, like those that may continuously fail in treatment due to the large data set that's created. So I want to talk a little bit about our particular project. We will be extracting de-identified data from electronic health records and billing records from the 25 or 24 rural providers who are part of the Integrity Partners for Behavioral Health Collaborative, merging them together into a data warehouse with the ultimate goal of improving client outcomes while decreasing cost. So where we're at with the project, we have written permission from the New York State Office of Mental Health, and we've gained IRB approval here at UB. Our data warehouse involves extracting data from 9 different electronic health record systems. It includes over 50,000 clients across all age groups. So we'll have children and adults, families, and so forth. Services include all outpatient services being provided across those providers. This will be psychiatry, counseling, case management, PROs, housing programs, whatever the services are that these outpatient clinics are providing. We're extracting the data going back to the year 2017 and going forward. So the beauty of that is that we have pre-COVID data, post-COVID data, so that we'll really be able to examine some important questions or new questions that arise that we'll be able to look at through the data within the data warehouse. Our analysis in the project is wide. We're going to be doing continuous quality improvement reports, CQI reports, both project-wide, but also for each organization specific to what their CQI report requests are, to assist them in improving delivery and decreasing cost. Integrity also has 60 other partners that provide ancillary services whose data may well be added to the warehouse at a later point. In time, because we're ambitious, we would like to work on expanding the partners, potentially include data such as education, criminal justice, healthcare, and so forth into the data warehouse for further analysis and learning. Currently, our work is primarily focused on data extraction into the warehouse and the design and preparation of reports, identifying research questions. I want to add that we're doing that, both the report design and the identification of research questions in partnership with the treatment providers. We have committees across the partners who are contributing and helping guide the reports that would best benefit them and the critical questions that they would like to find answers for in practice that they're facing. Certainly moving forward, we welcome our colleagues from other UB partners to collaborate with us on research projects and grant writing to maximize our overall contribution to science. It's going to take all of our best thinking to really be able to maximize the data warehouse information and leverage it to really be able to improve outcomes for the clients that we serve. We also will be looking for funding opportunities to expand and maintain the data warehouse when our current funding finishes. So in closing, I just want to just speak briefly as to why this is a particularly meaningful project to me. That it's focused, primarily on rural communities is important. I'm from the Southern Tier. I was raised in Chautauqua County, and my decade of practice experience in mental health and social work was in Cattaraugus County. So what I know, and we all know about rural communities, is that they have particularly high rates of poverty, often have limited transportation and employment opportunities, unreliable internet access, as Dr. Chang mentioned previously, as well as decreased access to mental health and health professionals and services. I think this speaks to the importance of our project's timing and our goal of improving client outcomes for those struggling with mental health and substance use disorders living in rural communities, and will allow us to really leverage the data to get answers to the question the communities want answered first. So thank you.
One of the questions I was going to ask you, you answered, which was how can other researchers at UB connect, and or community partners, and it sounds like that's really the goal of yours, that we work together on this. That's very exciting.
Yeah, absolutely. Yes, always looking for community partners and colleagues across UB and outside of UB as also have expressed interest, and we're talking with them. So thank you.
Thank you so much. All right, we'll start our second round of questions, and if I can get them in the right order, we'll do We're back to Dr. K. As we reflect upon the time before COVID and as we consider the future, what are the newest approaches to training in mental health? How is your department, along with other areas, preparing our future physicians for treating and informing care?
So I started to talk a bit about that in my first response, and I'll spend a little bit more time walking through what we're doing there. But I also want to say that our department is involved from the beginning of medical school with medical students in all 4 years. We have various educational opportunities for them. And then running through into our general psychiatry residency, we oversee a 3-month experience in child psychiatry for all the general psychiatry residents. We also have a 2-year fellowship program in child psychiatry for people who want to become child psychiatrists. And we have 6 of those, 3 per year, so 6 in total. We also are involved in training of pediatric residents and neurology residents as well, who spend time with us. So we're involved in medical student education to a great degree. We also have some involvement with nurse students, PA students, but the bulk of our teaching is focused on the residents and medical students. As I was mentioning before, no matter how much we do in terms of training child psychiatrists, we're not going to come close to meeting the public health need that there is, and there need to be other professionals involved. Obviously, there's a large cadre of mental health professionals who are very involved: social work, psychology, masters in marital and family therapy, mental health counseling, and so forth. But there are a limited number of folks who are able to work with some of the more difficult kids and who often need medications. And that's where we in particular have great shortages. And that's where we've looked to primary care. And so through Project Teach for the last 10 years, we've been working to provide ongoing formal CME education for pediatric primary care folks. All those programs are free. They're open to anybody in New York State who's a pediatric provider. Nurse practitioners, PAs who are working with kids are welcome. We in particular like to be involved with folks who are working in primary care settings, but we have lots of nurse practitioners who are psychiatric nurse practitioners who have done training with us. And we have a variety of modalities. We have a website. The Project Teach website is open to anybody who registers and has many modules on there that also have CME if you sign up for it. But we have programs that you can take a look at on anxiety, depression, a variety, ADHD, many different topics in child mental health. And so the website is another thing. But we go into practices, we do trainings, we have lunches. We also have what we call our intensive training, which occurs a few times per year. And those videos are also up on the website, and you can take a look at what that is. That was a 1.5-day program followed by 6 one-hour echo type programs. And we've always felt, though, that the education, the formal education, has to go hand in hand with the consultation support. So we have a 1-800 phone line for pediatric primary care folks. They call us Monday through Thursday, 8 to 7, and Fridays, 8 to 5, and they get one of our teams. As I mentioned, there's 5 universities involved, and we cover on Thursdays. So you get me if you call on Thursdays. We have a team here in Buffalo consisting of one of our LCSWs, Kristen McGinley, myself, and Beth Smith and Saravson, other child psychiatrists, and we cover the phones. We also are able to see kids for one-time evaluations. So we try very hard to work with primary care folks so that they develop the skills and the confidence to be able to take care of more and more kids with what we see as mild to moderate mental health issues. We're not looking for them to take on the kids in the deep end, but we really want them to do so with the mild to moderate. And it's really been very gratifying over the last 10 years.
Thank you, Dr. K. That need to build the workforce is so important. And actually, we've been surprised in the School of Nursing this year that our psych mental health nurse practitioner program has had a much increase in enrollment, as well as our certificate program. Really pleased to see it. I think the more we can spread the opportunities around to meet the needs of our young adults, our children, as well as our adults, is very important. Thank you.
Yeah, there's a tremendous need, and we're not getting close yet to meeting that need.
Very, very true. All right. Next question is for Dr. Marshall. What factors impact the mental health of our current medical students? How has this changed with COVID? And what models of care are being offered at UB or within the medical school to address the current needs, and how has care for our students transformed over the years? That's not one question, that's several, but pick and choose.
I think I can sort of mash it together. You know, I won't pretend that any graduate program is not stressful, but I can speak to medical students and the stresses of medical school, and they include the workload. The workload has not decreased over the last 2 decades. Our knowledge has, expanded exponentially, and therefore so has the material that goes on to step 1. So the workload, students have always struggled with imposter syndrome that continues. Students get into medical school and suddenly they look around and they think, oh my gosh, I'm not as smart as all of these people. The admissions committee made a mistake. I shouldn't actually be here. They're isolated, and that has been so much worse in COVID. I think the University of Buffalo did an amazing job, especially our anatomy faculty and our curriculum committee, in terms of making sure that when our students could be together, especially for anatomy this year, they were together safely, wearing masks, goggles, socially distanced. The anatomy faculty worked overtime to make sure that there were students there in the morning and students there in the afternoon in a divided class. But outside of that, our students were much more isolated than they normally are. And for those who were from out of town, they were not only isolated from their peers, but they were isolated from their families. They couldn't travel, they couldn't go home. There's always a lack of time reserved for self-care. Students don't get enough sleep, they don't exercise, they don't eat the right diets, they don't save time to relax with friends and family. That hasn't changed with COVID. And they have a pressure to perform from day one in order to get into that residency program that they want to get into. So it's just stress from the beginning. And what we've seen over the years, what I've seen over the years, and I know Dr. K has as well, is that the mental health system is difficult for anybody who isn't already in it, either working in it or being treated within it. It's hard to get an appointment. And so, it's difficult to find a psychiatrist or a therapist with availability in less than 3 months. That's always been a problem for our medical students. They open up the phone book or they open up the internet and they start looking and they start making phone calls, and people will see them, but it's in 4 months and the medical student is in crisis now. Insurance is being accepted. Our medical students come with their parents' insurance, which may be out of network. or they've got the school's insurance, which isn't accepted. And so that was a problem for, students for a long time, was just finding treatment if they needed it. And so when the medical school moved downtown, we started thinking about how we could provide improved care for our medical students on site. And about a year before COVID, the Department of Psychiatry made a proposal to Dean Cain, which he accepted. And that was that we have 2 psychiatrists be available to see medical students at the downtown campus, either on site or across the street at the Conventus building, flexible hours. So they can be available 8 hours a week. If we need more hours, it can be 10, 12 hours, but it is covered. The hours of the psychiatrists is covered by the medical school. The students can seek care for free. They can see one of the psychiatrists almost immediately. There's exceptional flexibility for our medical students. It's been extremely successful, and there are almost no no-shows. We do have a counselor from the counseling center who is also embedded at the medical school, or was last year. I think we have a new one that's going to be embedded at the medical school to provide counseling for the medical students. And that can be helpful for some students, but it always starts off with, you are limited to 10 sessions. So you have to get better in 10 sessions or we're done treating you, but that's all you have. And that's really difficult for medical students. And so we have a current proposal into to the medical school, that this Department of Psychiatry, to increase the time available from a therapist perspective. So we're looking to embed a full-time therapist, and hopefully more than one, so that there's a total of full-time provision, but also an increase in diversity, because we do have students who would prefer to see a therapist of color. And so that is currently one of the programs that we are working to develop, and that is more to come. So I think I got everything in there.
Wow, you did that very well. That's an impressive program. These students certainly deserve that, but that takes a lot for a school to pull that together. I'm very impressed. Okay, Dr. Chang. Now, how is nursing working together with other schools at UB and the community in addressing mental?
Sure. I'm going to talk about the experience that comes from our HRSA grant that we received a few years ago. So school nursing has received 2 behavioral health workforce training grants from the Health Resources and Services Administration, HRSA, in 2017 and 2019, with a total of $3.2 million in funding. And the purpose of these 2 training grants is to increase the number of well-trained behavioral health professionals to deliver care to people with mental health problems or substance use disorder, especially to those living in medically underserved areas, in an effort to address the shortage of behavioral health workforce. The school nursing has been working with faculty from School of Social Work and the Graduate School of Education on the grants to develop an advanced interdisciplinary training program on behavioral health for graduate students. The students who participate in this 1-year training program receive a stipend to offset their living costs. And this training program includes both didactic and clinical training. In the didactic part of the training, we have included evidence-based behavioral health interventions for mental health and substance use disorder. We also include content in cultural competency, social determinants of health, trauma-informed care, and interprofessional education and collaboration. And one of the highlights in our training program is to provide standardized patient simulation for motivational interviewing. The students in our training program really enjoy the patient simulation and found it to be a very positive experience. And because of that, we also provide additional training experiences for the students who wanted to learn more about motivational interviewing. And due to COVID pandemic, since last year, we have moved the entire training program to be delivered online, including doing the simulation through Zoom. And for the same reason, We added telehealth for behavioral health content into our training program as well. And for the clinical placement, we really appreciate our local behavioral health agencies and healthcare systems, such as Best Self Behavioral Health, Evergreen Health, Endeavor Health Services, ECMC, Jericho Road, Community Health Center, and Spectrum Health Services, just to name a few. They provide great opportunities for our graduate students to do their clinical training. These two HRSA grants have given our students with different professional backgrounds the opportunity to work together in the same training program, allowing them the opportunity to learn from each other. For the past 4 years, in total, we have trained 108 graduate students from the School Nursing Psychiatric Mental Health Nurse Practitioner Program, School of Social Work, Mental Health Counseling, Rehab Counseling, School Counseling, and School Psychology programs. We evaluate the outcome of our training program as well, and we are very pleased to know that the students were very satisfied with our program and provide very good suggestions for us to improve the training program as well. We also follow up with those students who complete the training program with regard to their career choices. And I'm happy to report that among those students who responded to us, more than 70% are currently working in medically underserved communities. So thank you for HRSA for this great funding opportunities, as well as faculty who are part of the training grants and those who provide the training lectures for us. It is very much needed, and especially for medically underserved area. So in conclusion, when it comes to the mental health, I think the greatest opportunity is trying to reduce stigma and addressing the services gap. Just as I talked about in my previous response, that there are social determinants of health which can negatively affect some people's ability to access high quality mental health services. And again, we are seeing that in disadvantaged and minority urban areas, as well as in some rural areas. And we hope that some of our training programs are taking steps to address those needs. But there is always an opportunity for doing more. Thank you.
Thank you, Yuping. Finally, the last question is for Catherine. As we reflect upon the time before COVID and we consider the future, what are the main topics that we need to think about when we consider mental health and wellness moving forward? That's not much of a question, is it?
Well, I'm going to have a brief answer, but before I do that, I just wanted to comment on how valuable those HRSA grants have been to the education of our students across campus, and particularly within the School of Social Work. It's been a very valuable opportunity for our students that have been involved with that. Social workers provide around 60 to 70% of all mental health treatment within the United States. So for our students to be able to have that experience of the interdisciplinary nature and that very specific training is very valuable, and an opportunity that students value themselves. So just as the last question, I'll just be brief, but what I think what I'll do is tie it back to research being done at UB and the data warehouse that I spoke about previously. There's lots of wonderful, important, critical research being done at UB that's answering a whole variety of questions. I know that in relation to the data warehouse project that I previously spoke about, that particular project is well positioned to answer many of the current critical questions we have related to mental health and substance use, as well as future questions we may not even know yet what they are, based on the richness of the data that we have together within this data warehouse. Some of the just questions off the top of my head is, what interventions are most effective and for who? In addition, learning more about COVID and what the impact has been on behavioral health, who's been most affected and how, what preventative variables are there that's helped people be resilient through this. I think, like as Dr. Tang had mentioned, differences in service delivery modalities is in person, telehealth, and a variety of different telehealth approaches on client outcomes. What are the client characteristics that benefit best from which modality? Let's start to do some matching in order to optimize outcomes. I think also interest is, particularly we'll be able to do with this data set, is look at differences in service provider and disciplines and client outcomes. We'll be able to look at client outcomes related to whether it was an MD or a PA that provided, or a nurse practitioner services, LCSW versus a licensed mental health counselor. How about our peer supporters who are, part of the treatment team? There's some interesting questions that might help us better match specific client characteristics to the provider that may be optimal for them for improved outcomes. Developing profiles and predictors of treatment success is really critical. And on the other side, identifying those who are treatment resistant and testing alternative approaches. There's an unlimited amount of other questions that we'll be able to allow it to ask that'll bring us to really bringing precision medicine into behavioral health care as we move forward away from treatment as usual modalities to customized treatment models based on science. I think that the future looks bright for mental health, and there's a lot of good research being done at UB that'll help move the field forward and optimize the best outcomes for the clients that are served. Thank you.
Well, I think you did a wonderful job of summarizing there. Thank you. We were hoping to have some time for some questions from the audience, but we've had such a rich discussion here. I think according to Jennifer, we may just not be able to do that. But I guess I would like to, we could have gone on for another half an hour easily, I suspect. But I would like to just offer to the panelists, is there anything you heard that you would like to comment on? Okay.
Well, one thing I just underscore, we've talked about the role of telehealth, and that really came online in the past year during COVID. And I think that's here to stay unless something crazy happens with payment for that. I think that's largely why it was underutilized before. That is that providers were not paid for doing telehealth by and large. With COVID, all the insurers agreed to do that, and virtually all mental health treatment, outpatient mental health treatment, became virtual the past year. I think that's going to continue into the future. Many people will prefer it. It's not the same as seeing people in person, and there's still a big place for that. But I think the opportunity for that is going to be there. I hope it is, because as someone else mentioned, it's led to much better attendance at appointments. And it's easier for everybody. It's easier for families, for kids, for adults. So that was one thing. And another thing that we haven't really talked about in terms of the future, but I think is a tremendous step forward, is the use of family and peer advocates and mentors. And that is happening more and more in the community. And I think that's going to be an exciting movement in the future.
Thank you so much. Any other thoughts?
Marsha, there is one question in the chat, and I don't know if anybody wanted to provide any insight on it.
Sure.
We were asked about healthcare providers and if there's any research or studies being aimed at risk healthcare providers at this time.
Looks like maybe we're not quite as familiar with that. So
Provider.
we're talking about the
Burnout.
at-risk health care providers. Is there some research on that?
Yeah. Provider burnout,
Right.
their mental health issues.
Well, I think Dr. K mentioned, at least in terms of COVID response and the burnout that, you know, many of our healthcare providers at ECMC and Kaleida may have been facing. We did have the warm line that was available for nurses, doctors, therapists, any healthcare provider at Kaleida or at ECMC, inpatient or outpatient, was able to call the warm line, I'm sorry, which was running and I think is still running, and is staffed by a psychiatrist. I think it's 24/7, David. Am I?
I think it's more like 12 hours a day, something like that. It's substantial. Yeah.
And that has been really helpful. I think that the use of that has dropped off a little bit in the last few months, but it was being made use of pretty significantly last spring.
How do healthcare providers know to have access to that particular warm line?
It's advertised. Yeah, go ahead.
There's during COVID, there have been weekly or sometimes more frequent newsletters that have come out from the medical directors or their surrogates. And so we get an update every week or twice. For a while, it was like every day. How many COVID patients are there? How many are in the ICU? Here's what's going on at the hospital. Here's what's going on there. It was a capsule summary, and it had that listed in that. So people could see it every day. They also, Kaleida has been having mini grand rounds every Wednesday morning, and they've had several on mental health where we've mentioned the warm line.
Thank you. Well, I was supposed to summarize, but it's 1 o'clock, and I think my summary is that I've learned an awful lot in this hour about what is happening at UB and how we are reaching out, and we'll continue to do that. And I think we all now have a better handle on what people are doing so that we can do even more connections among our schools and with our community. So I thank the 4 presenters. When I was reading your little introduction, I thought, well, if you're going to want someone to come and talk, you invite someone who's very busy, and each one of you, given the number of roles you have, are very busy. But I thank you for coming and sharing with each of us and with the very nice size audience here, some important things that we all need to know. So I hope you all keep looking for the next distinguished dialogues. I'm sure they will be coming along soon. Thank you so much for joining us. Bye-bye.
Thank you.